Thank you everyone for coming tonight. Definitely thank you to our esteemed panel and our moderator. So moderating for us tonight is Chris Jenkins. He is the COO for St. Francis Bartlett. On the panel is Tim Slocum. He's the president for Methodist University. Next to him is Joe Vaughn, and he is with the VA. And then on the far end is Paul Cade. He is with Baptist, and so we are grateful to have you all here tonight. Also want to thank our sponsors who make programs like this possible. Our sponsors this year have been Methodist, St. Jude, Regional 1, St. Francis, and Baptist. So definitely want to express my gratitude to those organizations. Without further ado, I will pass it on to you.
All right.
You don't have to stand if you don't want.
Okay, perfect. Everybody can hear me. I've been told I've got a loud mouth. Right? Okay. Well, and want to welcome again everybody for being here. Thank you, Scott. Thank you, gentlemen. It seems like every year and for the foreseeable future, at some point we need to talk about how we respond in crises, right? How we respond to a disaster. What can we do from emergency management to get better? You know, we went through a 2020 year that had a little thing called the COVID. This is in the history books already for my kids, I learned. But we learned a lot. And I think we learned a lot on the fly, and we learned a lot very rapidly. So the series of questions we have tonight are really to grab y'all's expertise so we can take those nuggets of wisdom back to our office and hopefully share them with our teams. So we'll go ahead and get started. The first one, everyone's very busy. I hear you guys occasionally will have a meeting on your calendar, maybe get an email.
Every once in a while.
Every once in a while, and sometimes they give you reports, right? Spreadsheets.
Yeah.
So how do y'all keep up to date in the face of everything you gotta do, right? We've got finances, we've got the people aspect. How do you guys keep up to date with something like standards for emergency management and preparedness? And why don't we start with you, Tim?
Yep. All right, well, good evening, y'all. Appreciate Baptist for hosting us tonight, and welcome to this event. So keeping up to date on this, I think there's a couple of things, right? So we're all accredited by the Joint Commission or some third party, DNV, and so, you know, there's the base level requirement there that, you know, as leaders, I think it certainly makes a lot of sense to avail ourselves of training around that. You know, and then going from there, in the event of a crisis, the I believe it's National Incident Management System, NIMS, has got the Hospital Incident Command System, HICS, that has got some good training. What I like about that is that it provides kind of a common language, right? So, you know, if you've had HICS 100, 200, 700, and 800, then there's common vernacular there. And so I think we got to start there. But in terms of staying up to date, I think it goes back to doing an annual kind of risk assessment at least. And so, you know, we at Methodist, and I'm sure these guys would agree, are constantly looking at what are we at most risk for. And so it could be a cyber attack, it could be some sort of weather event. I'm sure a pandemic, a 100-year pandemic was on that list at some point. But then, you know, doing tabletops and doing kind of assessments and evaluations for each of those certainly kind of keeps me on my toes, and because it forces me to ask questions to which I don't know the answers, and so I've got to go to other subject matter experts to find out. So that's on top of the reading and, you know, just kind of talking to others in the industry.
Joe?
So I think in addition to what Tim said, I've had opportunities when I go to ACHE Congress, there's usually some type of emergency management offering. We also pay a Joint Commission consultant to come in and help us get ready for our next triennial survey, and certainly they help out. I think also being able to put into practice what you learn and actually physically go through the motions and commit it to memory, and I guess for lack of a better term, get some muscle memory with it. We are a federal coordinating center with the Air National Guard, and we try to do a couple of drills with them every year, so we can also capitalize on what they've learned and what they can show us, even though I end up being in charge of it and my emergency manager, but we certainly learn from them. We also do some drills in the facility, probably try to do one at least every quarter. like Tim mentioned, cyber security. We've done active shooter drills where we have, people run around with pretend guns and that type of thing. Certainly, one of the threats we see in Memphis, unfortunately, is we see our most likely threat is an active shooter. So we've done drills with that and learned a lot from it. Trying to think if there's anything else. Standing up our, as Tim mentioned, it's actually a requirement in VA for senior leaders to go through the whole incident command system training, and to the point of even going to Anniston, Alabama, and they have an old Army hospital there that you go through the training. So I'm fortunate that Big VA makes it a commitment to actually go through all the training and learn how to use all the forms and that type of thing. So I think having a commitment from the organization overall makes it a little bit easier to walk away from some of the emails and things you're talking about and leave somebody else in charge and go get trained up and bring it back to the facility. And certainly when we do mock incident commands and things like that, make sure everybody knows their role and what they're supposed to do.
Yeah, I really appreciate being on this panel with Joe and Tim and being around their expertise for sure. I'll just add, I think, certainly we do the same thing that these guys do as well. We're fortunate to be part of a healthcare system that has a system manager in our corporate office that really does a really good job with regulations, regulatory requirements, policies and procedures when it comes to readiness. And all of those policies and procedures are kind of sent down to service line leaders, market leaders. Then we send that down to the CEOs for training with department directors and managers. They get with their employees, frontline employees, and train them. We also have what's called Health Streams. It's on the intranet for Baptist that does training for all of our employees. They have to do that annually. It's not just training, but it's a test they have to do every year as well. So that kind of keeps them up to date and keeps us up to date too. I think one of the great things that most healthcare systems have, I think all of ours here, is it's having a badge with all the codes on it as well. Mm-hmm. And in certain situations it tells you what to do. It's kind of a joint commission requirement, but it really helps us with disaster planning.
And has there been anything you've seen from that's kind of risen up over the last couple of years as far as alternative ways to educate and learn? We see the commercials that say, I learned it on TikTok, right? Is there anything that you've seen over the last couple of years that you've been pleasantly surprised about as far from an education standpoint for executives or even your leaders?
I'll start. I think, for us, we try and engage folks other than the usual suspects in incident command. And so there's no better way to learn than doing it, right? And so I'm thinking about the last tabletop we did as an executive team at university. I think I told them, all right, I'm on vacation, and so I'm not going to be here, and so and so is not here either, and so we're putting people in different places than they might normally be. And so there's no better experience than teaching, than doing rather. And so that kind of jumps to mind for me. I think, Joe mentioned ACHE as a vehicle to learn about some of these things. I found benefit there as well. Those are a couple that jump out.
Okay.
Yeah, I think we had that opportunity, same opportunity Tim mentions, for people to jump into roles they aren't normally in during the pandemic, because we stood up incident command thinking it was going to be initially, I think everybody thought a couple of months and we're going to be done with this, and 2 years later we still had incident command on a virtual basis. So it gave us opportunity for a lot of people to rotate through. Even from the beginning, when I thought it was going to be 2 months, I did not take on the role as an incident commander. I had my COO do that job. I was like, somebody's got to run the hospital. This is not going to be a week-long thing. And and she really took the ball and ran with it. And then when she would, like Tim mentioned, when she would be out, you know, she still had to take time off and stuff like that, and other people would step up. So I felt like at the end of, you know, probably the first 6 months, we really had a lot of people that could step into, you know, have different vests on that they wouldn't normally wear during that process.
Yeah, so, you know, certainly during COVID, we kind of had to do things differently. And a lot of our training was on Teams. Sometimes it was not face-to-face. I agree with what these gentlemen talked about too. You know, having, you know, the exercise is really important. One of the things that we did in Columbus, Mississippi, where I came from, I was the CEO there for 15 years, is we partnered with the community, just like everybody else does, the fire department, police department, ambulance service. But one of the things that we did that was very helpful is we partnered with the colleges, the nursing schools, allied health providers such as respiratory therapy, et cetera, and they participated in our drills as well. It was very helpful for their training.
And that's a great segue into one of our other questions, which is, you know, we talk about communication inside of our organization, but not everybody has the same domain email address. Not everybody is on, whether it's Tiger Text or, you know, whatever the alerts are. How do you handle getting education, or specifically getting information out to the community about unforeseen events, unforeseen circumstances?
So I'll go first. So one thing we definitely use a lot is social media to get, you know, if something's happening at the facility, unexpected closures. I know, like last year when we had the ice, we definitely used social media to get that message out pretty quick about clinic closures and things like that. We also give veterans the opportunity to sign up. We call it vet text. So, and the majority of them do sign up for it. So again, if we have a situation like that, it will blast text messages out to all of them with what's going on. You know, public affairs, I require them to have a solid relationship with all the media outlets in the area, so we can get the word out that way. So probably to our patients themselves, though, the ability to text them and social media works best for us.
Tim?
Yeah, so I would echo a lot of that. Internally, you know, probably doing a lot of the same things that the other people in this room are. We're texting, we're emailing. We've got a secure kind of mass messaging app for our associates that we use as well for situations like that. Externally, social media to some degree, use of traditional media, again, kind of getting the message out there. Kind of mine.
Yeah, the texting is really helpful. You know, everybody has cell phones now.
Right.
And so we have what's called Everbridge. So if there's a disaster or something that's really, really important, we'll text our employees. We did get, the same as Joe said, we did get social media out quite often. We also have a marketing person that sometimes is interviewed by the television, especially if the police is involved in anything. So those are some of the things that we do.
How do you take the information or education that you're getting out to your staff, right, that you see day in, day out? In some ways, we compensate them for drilling and being prepared. And how do you take that and get it to both your medical staff, and how do you get that to the board? Obviously, those are two very different groups, and there's going to be different requirements during unforeseen events. So how do you roll that out?
Yes, typically with the medical staff, now it kind of depends on the medical staff, but here they prefer email, and they don't want many things on email, but they do want the important things on email. So we have come up with just really a consolidated weekly update to give our medical staff. So that's one of the things that we do. We still text them too, because you know they're into that as well. So those are some of the things we do.
For the staff, similar situation. We have a alerting system that we can send text messages or emails out to staff. So that we not only use in crisis or emergency situations, but if there's something urgent or important we want to get out, we have that ability to do it with them. We're also in the process, we haven't implemented yet, we're working through the contract to have TVs in all the break rooms that are staff facing, and then ones in the hallways and stuff that are veteran face or patient facing, that we will be able to put custom info on, events that are happening, any kind of urgent messages, that type of thing.
Yep, yeah, so similar things at Methodist. We've certainly got the routine kind of email newsletter that goes out that's meant to be kind of concise, hard-hitting, short and to the point. We also do medical staff town halls, and so, we will have kind of reports out from our major services, and an opportunity for interaction with system leadership, with IT leadership, could be medical affairs, those kinds of departments. And so we, try to make use of those as well. On the board perspective, when I think about that, we're intentional about balancing the fiduciary nature of the board, but not overwhelming them with operational minutia either. And so, I think a lot of approaches there, are presenting risk assessments. As a health system, here's how we're risk assessing our biggest risks. And, at a high level, these are our mitigation plans for this. So we're communicating to our board that, we are proactive in our approach. We are anticipating potential issues. And should those issues arise, here's how we are planning to address those.
Have you seen the boards move more to asking for more information once you open that door, as it's related to, whether it's been the boil water advisory, whether it's been the snowstorm, ice storms, or even the pandemic? Have you seen them become more engaged or try to be more engaged in something like the operational side of the house?
I think that varies kind of board by board,
Okay.
is what I've seen. I think you've got some that are more operationally minded, others that are less operationally minded. Certainly anytime you've got something with a potential, large patient safety impact or a PR impact or, heavy financial exposure, certainly they've got to be aware, and they may or may not take greater interest in that. But I think that kind of varies by kind of board by board.
Yeah, I think it kind of varies by individual as well, because some board members may prefer, more information and others may not. And certainly if there's something big that happens that they need to know about, we will give them a call, personal phone call, so, to all the board members.
So I'm lucky with the VA, I don't have necessarily a board of directors. I report to a network director that has the 5 VA hospitals in Tennessee and Kentucky. And so the calls with them are more, do we need any resources from one of the other 4 facilities, if there's any way they can support us, if there's something going on. They don't tend to try to run our operation from Nashville or anything like that.
Good. All right, thank you. Okay, so obviously we have some pretty good standards out there from either the Joint Commission, DNB, or the other regulatory bodies. But everybody's a little bit different, right? Every executive, every CEO, everyone likes to see a little bit different information. What assessment tools, let me ask this, what has been the best assessment tool that you used, and how have you tweaked it kind of to your own leadership style? This looks hard, so I'm going to start with Paul.
So specifically for
any unforeseen situations, unforeseen events.
Yeah. So, we have an internal tool. If we, have any type of exercise, then we'll go over that specific tool. But I can't think of any external tool that we currently use.
So for VA, in our emergency management program overall, there's a risk matrix that for any type of natural disaster or well, not necessarily even natural disasters, but even like active shooter or you have a fire in the building, or it covers just about anything and everything. You sit down as a team and go through it and develop, what you think the risks are, where you've got opportunities, threats, weaknesses, that type of thing. So it's a very time-consuming tool, but it's a very thorough tool, in my opinion.
Yeah, I'll start with kind of the after-action review. I think of it as kind of a plus delta mindset. And so from the plus perspective, are there particular individuals or departments that we can celebrate, who did a great job? The pharmacy really go above and beyond in responding to our facilities division, go above and beyond in responding to whatever event. But on the Delta side, the next time this happens, what should we do differently? What we learned, what happened, why did that happen? And, for the next time something similar occurs, what should we do differently? During the event, I think it kind of varies by event. And so, two that kind of come to mind for me are weather events, something like a tornado that could affect, any of us represented here in the room. And so at that point, what I'm interested in hearing kind of in the moment is, any associate injury, any patient injury, any exposure to our patients, any facility damage, what's the status of our infrastructure systems, building envelope, that kind of thing. Shifting gears to COVID, when I think about those days, some of the things that we reported out daily at Methodist was number of patients, number of staff infected, number of ventilators we had available, of course, current census and all the capacity metrics. And so I think, what we're reporting has got to be tailored. And going back to COVID, that list grew, right? I mean, what we started with on day one was probably a fraction of the data that we were reporting by the time we shut down incident command.
Thank you. All right, how do you track and report information, meaning specific to disease-related mortality, things of that nature? And how do you exchange that both within your organization and outside your organization?
So I'll start. So at Methodist, we've got, we have the organizational performance tracker. And so we will build kind of it's essentially a balanced scorecard is what it really functions as. And so from a pillar perspective, what's going on with each of the major pillars, that are out there. And so we set metrics for all of those, targets for all of those, and then we measure our performance against those. And so that is communicated internally on our intranet, using kind of the quality pillar as the example. That varies by hospital, as you would expect, and so I'll use, transplant is done at university, and so we're the only hospital that reports on our transplant quality metrics and outcomes. And so, there's a scorecard that's done there, and we're scored, and those scores kind of roll up for each of those pillars. And so it's transparent to our associates and our medical staff in the building.
I think ours probably got pretty famous right after the whole incident in Phoenix with the access there. The cell report, we refer to it as. So it takes, on the very surface of it, about 26 KPIs and it used to give a star rating for each facility compared to similar facilities and anywhere from 1 to 5 stars. And VA kind of self-inflicted gun wound there. They weaponized it to a certain degree, so they dropped the stars. We still use that same tool, and it's been tweaked over the years. And it's pretty helpful for me because you can go in there and you can see in a really neat radar chart where all your metrics are, what quintile you're in compared to other facilities. And it's got a lot of built-in tools to tell you where your opportunities are to improve within a specific measure. And it has everything on there from mortality, adjusted mortality, infection rates, broken out by the different types, central oncology, that type of thing. So it's been really helpful when it's not being used when it's not being weaponized, against facilities, and everybody's not so focused on the star ratings, but where you're improving.
So at Baptist, we also partner with Vizient, and we use some of their databases, compare ourselves to other hospitals, like-size hospitals, and for several different quality measures. The other thing is, internally, our quality department has just tons of measures that we look at, from mortality to readmissions, et cetera. So we're constantly comparing ourselves to like-size facilities, but we also compare ourselves to the Baptist facilities too.
This might be a little bit, I guess, Joe, we'll start with you on this one and we'll see where I'm going. But how do you leverage local, federal, state resources to help with events? I mean, what has been, and kind of tailoring this to each individual, whether it's here or whether it's been other stops in your career, but how do you create that relationship, and how do you leverage those to get the best for your patients and get the best for your staff?
So for us, I think we try, when we're having our exercises, I mentioned the Air National Guard a while ago, but we also loop in a lot of other local, state resources, not so many other federal agencies except the Air Guard, but certainly where we can partner up. I know at my last place, we really partnered a lot during the pandemic with the public health department, and there was only one other private hospital, so we had partnered with them. Even like your local media to get messages out and things like that. But I think waiting until you have a situation on your hand is probably not a good time to start establishing those relationships. So fortunately, we, in our tabletop exercises and stuff like that, had invited them in and already had at least a cordial relationship established, and knew who the contacts were, and had phone numbers of who we needed to call when things started really getting hot and heavy.
So our corporate office really does a good job of leveraging federal grants, state grants, local funds as well. I know this hospital, at one point we needed to have a water tank brought in, and we were able to work with the state to get that brought in. Also during COVID, Army National Guard was able to kind of support us with RNs here at Baptist Memphis, and we all benefited from the COVID money, because I don't think many hospital systems would have made it without the COVID money for those 2 years. It was pretty much a lifesaver for all of us.
Yeah, so similar stories at Methodist. I think locally we're fortunate to be able to partner with a number of agencies, and I should have mentioned this earlier, but it seems like annual disaster drills around the airport, since we are such a logistics hub here. But having the local partnerships, and with Memphis Fire is a good example. Be able to work with them to simulate a mass casualty event or some sort of large event. On the state level, we've had similar success with the state for kind of pulling down resources, if you will. Nationally, I'm thinking back in a prior role, I've only had to work with FEMA once to justify spending and get reimbursement for that. But, I found the process to be fair and, while a little tedious maybe, I think it was the right thing for us to do. So I've had good success with that in the past.
All right. And again, drawing back on any of the experiences, any stops in the career, you land, you're dealing with a health crisis, you're dealing with some sort of unforeseen situation. What are some of the areas that you find really need your attention as an executive, whether it's water, whether it's ice, whether it's COVID? What are some of those areas that you find as an executive you constantly need to hone in on to do better?
Yeah, so mine is communication.
Okay.
When I think about this, and what comes to mind for me was the pastor of the church I attended for quite a number of years used to say, people are down on what they're not up on. And that has stuck with me for years and years. And so as an area that I always, when I'm evaluating my own performance in some sort of issue, I don't know that I've ever been satisfied with the amount of communication that I am doing individually, that we as a team are doing. And so there are a number of things that everybody in this room is a leader in healthcare, and so there's just nothing that can be substituted for your presence, your listening ear, your hearing directly from your team. And so that's kind of what comes to mind immediately for me.
Joe?
I think, very similar to what Tim was explaining. Know what's going on with your staff, and then come up with some ways to help them deal with the situation at hand. I know when the pandemic started, probably about 6 months into it, the facility I was at the time, our chief of psychiatry came to me, and he had been in the Army and had been part of a team that they called it operational stress control, or like frontline battlefield type, mental health treatment. So he approached me about putting a team together that would go around, talk to staff, and kind of gauge what was going on in their mind and that type of thing. And we were doing a WebEx meeting every day where our infection control doc would give them the real, info on what was going on with the pandemic at the time, and how to protect themselves and that type of thing. But then we kind of took it to another level with that info. And so, I'm an empty nester. Childcare was not a big deal to me. Well, coming to find out, it was a huge deal to a lot of my staff. So we had, people from schools come in and talk about resources that were available, and other folks, that had compiled child care centers that were still open and we were still taking kids, and a whole host of other things that we were able to address just by that group going out and giving me back information on what I needed to focus on, and then me and my team going and getting these experts to come in and address some of those concerns.
Yeah, I think too, communication is certainly number one. But as you think about the future of healthcare, I think every hospital needs some help when it comes to trying to recruit more people to your hospital, whether it be a nurse, whether it be a respiratory therapist, lab tech, etc. So finding ways, working with the government, trying to find ways to scholarship to get more people interested in healthcare. That's really a huge need for us right now. Because you want as many people as you can get to take care of patients. You don't want to be on diversion, and you want to have the ability to take more patients and be able to handle an emergency when you need to, and be prepared for that.
All right. This one goes a little bit off script, but what has been the biggest positive you've seen in leading through healthcare crises or an unforeseen situation?
I think to me it's the spirit. I mean, it's the spirit of our employees that's gone through it. And I know my first CEO job was in Forest City, Arkansas, and that was in 2002. And we had a disaster there where there was a tanker truck that came through, caught on fire, and it was carrying some really dangerous chemicals. It actually exploded. And so you have to understand that sometimes your disaster plan may change given that situation. What happened in that situation, the fire marshal came in and said, hey, you're going to have to evacuate the whole hospital because all the smoke was going to the hospital. So the spirit of our employees was really, really good. They, the plan was for a bus to come and pick up our patients. We only had about 25 patients, which was good. We didn't have anybody on a ventilator, which was great. We didn't have anybody delivering a baby at that time, which was wonderful. And so we were able to move those patients to the church. And we were able to stay there for the rest of that day. But just seeing the spirit of the employees and the teamwork is just really rewarding to me.
I think, yeah, definitely people pulling together to get the mission done was very inspiring during the whole thing. But I think some of the innovation that came out of it too, you all of a sudden saw all this stuff happening with 3D printers. I had the same infectious disease doc I mentioned a while ago created this portable thing you could cover up from about here up and then out for people that were positive, and because you couldn't get your hands on that kind of stuff at the time, or it was taking forever. So some of the innovation that it sparked. I think there was something with the space program one time. It was said, I forget the exact wording now, but anyway, crisis will spark innovation, and it certainly did in the pandemic for sure.
Yeah, so I would echo these two guys. I mean, certainly the passion of our team, right? I think about our medical staff in the early days coming together and talking about what this is and what it's not, and, you know, you remember kind of the fog around all of that in the early days, and the passion from our medical staff, the passion from our associates, regardless of role. You know, I think about some of the work that our pharmacy did, our facilities team did, our radiology team did. It truly was inspiring, you know, as we worked through that. And I think, you know, especially in the early days, I mean, it was really kind of watching the best of American healthcare come together. You know, on the innovation front, you know, I think that's dead on. You know, there were things that, you know, we at Methodist had kind of talked about doing, and then, I mean, overnight, yep, we're doing this today.
Right.
And so there was some of that, but there were also just innovative ways to extend PPE or generate more PPE, or, you know, I remember those days. And, you know, certainly I think back on that, and those are some of the positives that kind of come to mind, you know, that came out of that. So.
All right, spirit, innovation, and passion, so those are great. So we want to save some time for questions, obviously, from the audience. So last question. I'm a new leader, new CEO. I'm in a small town. You're my mentor, or you're one of our mentors. They call you and say, oh my goodness, I've got this situation going on. What's the piece of advice you give for somebody dealing with their first one? Paul?
Dealing with their first disaster.
Let's say first disaster.
Yeah.
Let's just make it easy.
Yeah, I think number one is, you know, you don't have to panic. You've got good people around you. You have a disaster plan that you can rely on. Sometimes that disaster plan may change a little bit depending on what the situation is. And, you know, just a lot of encouragement that, you know, you can get through this because you've got experienced management. You've got an experienced management team that's around you. They know it. And you may be fairly familiar with it, but you're not completely familiar with it because you're a new CEO. I experienced that in Forest City when I was there 2 weeks before that incident happened. So, but I was very confident in the guys and the plan that we had, so it worked out extremely well.
Literally a trial by fire.
Yeah, absolutely.
So I think similar, I would tell them, just keep in mind, no good battle plan survives first contact with the enemy. There's going to be changes. Don't, you know, lose your cool when those changes come. Trust your team. And then I think similar to keeping your cool, you're not always going to have all the info you want to make a decision. Don't be scared to make it with what you have, but don't be scared to change it once you get more information.
Yeah, I think that's dead on. You know, the first thing is to remember that as the leader, you need to be the thermostat and not the thermometer.
Right.
So that comes to mind immediately. And so your tone, your reactions kind of set the stage. Secondly, pull on the team around you. You know, kind of as Joe mentioned, I think one of the things that makes healthcare great is that we get to work with people who are experts in areas that we are not. And just as I sit here looking around this room, I mean, we've got experts, we've got medical experts, radiology experts, facility experts, pharmacy experts, clinical leaders and experts, IT experts. And so that's a huge benefit in the face of a crisis, I think. And so as the leader, I think it's really our responsibility to pull on the experience of those experts with whom you've got around you. And so that's the second thing I would say.
That's great. I like that quote too. Thermostat, not the thermometer.
Yep.
Right. So Scott, t-shirts. Yep. All right. Thanks so much.
Thank you so much.
Absolutely.
Thank you to all of you for participating in the panel. We've got about 15 minutes. We're going to leave it open for question and answers. I'll remind everyone that the questions need to be specifically on the topic of crisis management, just because we don't have a whole lot of time. Does anyone have any questions for the panel?
Can I ask a non-crisis question?
We'll come back.
Okay. I have a question.
Yes, Mary.
In regard to the disaster and all the things that you had to do, and I'm curious about your contractors and your vendors, and if you had some sort of agreement to, during a disaster, we have this expectation? Or are you doing that now based on what you've learned from the past?
I think the only thing I ever ran into with contractors was that initially we had a really tough time with them with face mask compliance. And it got to the point where they didn't, in some cases, willingly comply with it, and we had to actually go back and do contract modifications and require them to do it. So yeah, that would definitely be a lesson learned, is to have some clause in every contract in case of emergency, you'll comply with current hospital policy, that type of thing.
Yeah, we had some of the same, as far as, not wearing their mask, so we had to address that. The other thing that we had was, some smaller vendors, that didn't want to come to the hospital during COVID. So we had to really aggressively address that because, there were mechanical type people working on certain things that needed to be fixed. So we had to get kind of aggressive and just tell them they had to come or we're done with them, so.
Kind of zooming out, speaking a little more broadly, I think having those relationships ahead of time is key. And so if you've got a facilities related event, having the relationships, having a good team around you and to call somebody who may be able to call somebody else to respond quickly is the first thing. The second thing that comes to mind is in the event of like a weather emergency, those vendors may be impacted just like we are, and so then you're trying to figure out how do we find common ground, recognizing we've got the same challenges is a second one. But I do think kind of thirdly to these guys' point, I mean having clear expectations, having clear kind of KPIs of those with whom we work is good. I can think of a situation in my past where I didn't think about ahead of time that I needed a relationship with vendor X for this situation. But as soon as we got that resolved, I was making a phone call and kind of setting even if it wasn't a contract in place, kind of an MOU to say the next time this comes up, you're going to be my first call. And so, let's talk about if that situation arises, what are my needs and how can we work together to mitigate any risk that we have.
I'll say this just real quick on the vendor standpoint. So my facility contracts out EVS, and during the COVID-19 pandemic, the hardest thing we had was our EVS staff, and it was the most critical. And it wasn't just because of availability they had the right number of people on their team, it was also from a transportation standpoint and being able to get them there. And so that really put a lot of people becoming experts in floor care and sanitation and stuff like that. So we ended up having to really work and put some penalties in place. Now the penalties are only good retroactively, right? Or retrospectively, I should say. But we worked with them to really get in some people that could help, and they ended up having to send people from other areas that they also covered. So it was a time-consuming process.
Thank you. Yes.
Is there a clear Memphis plan, regional plan, when we have, the disaster in terms of what hospital would focus on what and how our transfers would go?
So that's a good question. My sense is specifically no to that level of detail. What I've been told by, and I'll use Memphis Fire as an example, is they know kind of the capabilities of our facilities. And so given, a mass casualty event at the airport or something, certainly I think we probably all drilled on that here. We would upload into the local system what our bed capacity is and what our clinical capabilities are, so that then they would know how to field triage and respond appropriately. Now, with that said, in some of the meetings we've had with, say, the mayor's office, I can think about, and a trauma collaborative comes to mind as an opportunity where the various systems in the city have worked together to talk about how we might best respond to events. And so I think there's a loose framework structure for this in place, but in terms of the specifics around what hospitals have what capability or what bed capacity in any given time. I don't think it exists to that level of detail, is my perception, so maybe wrong.
So, interestingly, if FEMA gets involved and it becomes a federal event, usually they'll activate the Federal Coordinating Center. And so at that point, VA will work with FEMA, and usually the way I've seen it work, I've only seen it work one time, and that was when Hurricane Maria hit Puerto Rico. We actually activated the FCC in Jackson, Mississippi, and they flew people in from Puerto Rico, and then VA doctors would triage them as they came off the plane and then coordinate with the local community hospitals. So if they had kids and stuff and they weren't veterans, we had to get them out to other hospitals. So if FEMA gets involved and activates the Federal Coordination Center, then VA usually works with these guys, and we start saying, okay, we've got, these folks in triage right now, we need to find a place for them and that type of thing.
Yeah, I think it's a great question, because I had the same question when I arrived in Memphis, and I think it really kind of depends on the situation. It depends on the disaster. It depends on if it's a full evacuation type situation or partial. I think certainly we could handle a partial evacuation, but a full evacuation for this size facility would take more than Memphis, for sure. So.
I don't think you want one hospital just to be responsible for a specific, I think that's what makes it nice about working with everybody on the Office of Emergency Management of the State Healthcare Coalition, is that you want every hospital to be able to work not just up to their maximum capability, but also, as we say, surge and go above that if we need to in a disaster. We just did our mass casualty exercise, was it about 3 weeks ago? And we had cards, and we don't do pediatrics at our hospital, and we pulled out a card that said we had 3 kids arrive without parents. And one of our staff members said, we don't take peds. It's like, well, what do? You don't call them an Uber and then send them down to Le Bonheur. So you have to be prepared for that, and goes back to what these gentlemen said, which is you drill, you prepare, and it's always that anticipation of something's going to happen. How do you handle it there?
As a system, you all have other resources that you utilize. You talked about you do that, so I know in the VA you can reach out to individuals within your visit. How do you do other hospitals work that as well in terms of moving pieces around to support a hospital that's kind of in need?
Yeah, so we have a 22-bed system in the Baptist system. So we have a patient placement center, and that center can direct the patient to any open bed in our system.
And so Methodist has got something similar. We have I call it the IOC, the Integrated Operations Center, that's got visibility for all the bed capacity among the 6 facilities. And so if any one is in particular need, we will look and adjust based on what's available.
Same, when we're a 2-hospital system, we do have a transfer center that reaches out as far up to Detroit and all the way out to Birmingham for capacity on what we need to do for patients we would need to safely transfer, provided there's no other capabilities. But obviously, if we have a patient that shows up in our hospital and we don't have the capability for whatever reason or capacity to service them, we'd much rather keep that patient and family member in Memphis, and we would contact Methodist, contact Baptist, contact whoever, because we don't want it to be disruptive for the patient or the family member either.
Time for a couple more questions. Jane.
Paul, I was curious about the freestanding ER, how it's doing, and what your early challenges and successes have been.
Yeah, so that's a really good question. I'm really proud of it. It opened up January of last year, and the challenges right away was volume. We were not getting a whole lot of volume. We were averaging about 20 patients, and now we're averaging 42, and so it's really, really going well. It's a part of the Memphis Hospital, so the ED is a part of this Memphis Hospital. So typically the transfers will come here, but the transfers can go anywhere. So it's really going well. Started out kind of slow, but everything's going well. We're getting some really good patient satisfaction results in that location, And then we also have some diagnostics in that location as well.
Joe?
Yeah, I feel like we see in the news a lot about cyber attacks and disaster training around that. That's my biggest, I think, concern, especially as we move to a single EHR that runs everything in our hospital from the point of sale for pharmacy all the way to documenting OR procedures. How do y'all feel, I guess, as leaders, about the comfort of some of our readiness for that type of attack, or that type of disaster, I should say?
I'll start. So this is a timely topic. We were talking about this actually before we started. So at Methodist, and Scott, keep me honest, I guess it was October is what we said. No, yeah, October we did a tabletop on this very scenario. And so we pulled the senior leadership team into the Center of Excellence and said, okay, here's your scenario. And it was based on kind of real world events and experiences with hackers of health systems. And so we worked with a third party to go through, and that group kind of put us through our paces as a leadership team to say, okay, here's what happened, what would you do? What's the next decision you would make? What's the next decision you would make? And so they took us through that event. At the end of that, we did kind of a debrief and said, okay, what do we, did we make the right decisions, based on the information we had? What would we do differently? What do you see in the industry? All those kinds of questions. And then, certainly we've got to go back and we've got to do a gap analysis for any gaps that we've identified. And so, my sense is that health systems across America, this is an increasing threat to us. I share your concern about this. And so my read of the situation is that health systems are, at varying places along a continuum in terms of their preparedness for something like this to occur.
Yeah, I agree with that as well. And, we spend tons of money on the cyberware to make sure that our systems are extremely secure. The big piece also is really working with employees one-on-one, training them for phishing emails.
Yep, that's a good point.
Because
That's a great point.
that's what happens,
Yep.
Is you respond to an email and all of a sudden you're in trouble.
Yep, that's a good point.
So, we, on our email, we have a button that you can push for phishing and it goes, away. And then IS takes a look at it to see if it's a real phishing email or not, and then responds back to the employee, so.
Yeah, I think along those same lines, the thing that definitely worries me the most is employees not being vigilant. And luckily, our information security folks think about every quarter they do a drill where they'll pick a random number of folks to send a phishing email to them just to see if they'll click on the link and stuff. So I feel better about that. The other thing that kind of worries me is all of our access is we call it PIB badge, chip badge access, and people not being conscious of, I walk by and I see their badge stuck in the computer and they're off at eating lunch or something like that. So not protecting their access or, taking their laptop home. And I know there was a big story probably 3 or 4 years ago about the VA, and the guy had his laptop and had all this patient info on it and had it at home. It got stolen, and it was a big mess. I think he had every veteran that touched the VA system on that laptop. And, matter of fact, I used VA for care, and I ended up getting a letter offering me credit monitoring services and all this. So yeah, I think we modeled DOD's, cybersecurity and all that. What worries me the most is somebody just not paying attention and making it easy for someone.
Yeah, I mean, it happened here locally, and I can't go into too many details, but Scott, I know you and I had conversations, but it happened to us on a local level here last year, and it wasn't something that was actually caused at a local level. It would actually happen remotely, but the effects, and the biggest lesson I had learned was it not only did it knock out all of our access, so you have access to doors, access to computer terminals, but you also had a physical security compromise because you couldn't regulate who was going in off the dock, going back to the cath labs or OR. So that, and then you talk about Thumper and making sure your temperature, your humidity, those pressures are all being monitored to the best of the ability. And then finally, after all was said and done and the smoke kind of cleared, and luckily we had not gone through a phone upgrade our other campus had, so their phones were all down because they were all using voice over internet. We had not gone through the upgrade yet, thankfully, but we go through all of this and then we find out that we hadn't, that while we knew what we knew, we missed things like looking at radiation treatment plans and the archival of those, going back to find, making sure cath lab data, those pictures, the PACS imaging, all those things that we thought we were safe on, and then we created backups. But our backups and our redundancies were compromised because they all kind of followed that same path. So it was scary. It was a long, I think it was about 2 weeks, I think. It's a long 2 weeks without having to do that and then answer questions, but you still have to take care of patients. So a lot of lessons learned, and hope I never have to do that again.
There used to be a day and time not too long ago when healthcare was off limits for hackers. They left hospitals alone, but those days are gone. Just from 22 to 23, we've seen a 66% increase in cyber attacks in healthcare. So it is definitely, it's here, it's present, and it's getting worse. So it definitely behooves all of us as leaders to make sure that our people and ourselves are following those guidelines and getting trained as we need to. So this brings us to the end of our time. I once again want to thank our panel and our moderator. So thank you for being here tonight. Also, as you came in, you may or may not have seen it on the left-hand side. There was a place to sign in. If you want to get your ACHE credits, please sign there so we can submit it. Also, for these questions, I want to thank Missy, Dr. Wamadou, Eddie, Edward, Joe, and Jane for your questions. So that was very good questions. Thank you. We do not have our next program scheduled. However, we will be having a planning meeting coming up soon. We do have a planning meeting scheduled coming up soon, and our intention for next year is to do a much better job of at least having titles and dates, topics and dates set out, so that those will be on our website, so that everyone will know what's happening and when. We struggle with that a little bit this year, but next year we're looking to be able to improve on that. So be looking in January-ish to receive an update with notification that those are out there, and so that they're available to you. This concludes our meeting tonight. Does anyone on the board have anything that I overlooked that we need to cover?